for Health Informatics. So I'm presenting today on behalf of a broader team, most of whom are also based at UCL, but a couple who aren't. And so I'm going to be talking about our work looking at the evaluation of antithrombotic use and COVID-19 outcomes. I'm going to talk through some of our interim results from the English TRE. So quick recap on why we're doing this. So over the last decade, there's a class of drugs known as antithrombotics, which for individuals with atrial fibrillation, so regular heartbeat, who are at higher risk of stroke. Particular class of these drugs, so oral anticoagulants, when they're given are significantly reduced risk of stroke. You can see that in the chart on the left, which is a positive, but unfortunately there's still a significant minority of people who aren't on these medications, and so we sort of want to understand why that's the case. Also then, of course, in the last 18 months from the COVID-19 pandemic, which has introduced another risk factor, particularly for these group of individuals. And there's been some observational evidence internationally that antithrombotics, particularly anticoagulants, might offer some protection against COVID-19 outcomes such as hospitalization and death. So there are kind of three objectives to this work. The first was actually just making sure we've got an up-to-date comprehensive estimate of how many of these individuals with atrial fibrillation are on antithrombotics and different classes of antithrombotics, and building that in a way that we can reproduce it, in 6 months' time, 2 years' time, 5 years' time. And the second was then to look at kind of the why. So for those that aren't on antithrombotics, what are the factors associated with that? And then lastly, looking at the COVID-19 outcomes question and really trying to robustly determine whether if you've been taking antithrombotics prior to a COVID-19 event, whether that reduces COVID-19 specific hospitalization and mortality. So it's just a slightly more detailed overview of kind of how we've addressed those objectives. On the left-hand side, you can see a summary of the inclusion criteria, based off primary care, make sure you're registered, it's adults, it's got to be alive on January the 1st, make sure we've got consistent demographic data across the analyses. And importantly, they got the CHA2DS2-VASc score greater than or equals 2 and a diagnosis of atrial fibrillation. And for those not familiar with the CHA2DS2-VASc score, it's kind of a summary of how that is compiled on the bottom left with the relevant points in brackets. For the estimates as part of the first objective, we covered that across 4 time points from January 2020 to May 2021 to try and capture any changes across the pandemic. For the second objective, then looking at factor associations, we took the same cohort across, so no additional inclusion criteria, and then looked at antithrombotics versus no antithrombotics, and then subgroups, so anticoagulants versus antiplatelets, and DOACs versus warfarin. For then the COVID-19 outcomes, we looked at people who had any kind of COVID-19 event. So that could be a positive test, recorded diagnosis, or through to COVID-19 death on a death certificate. And we looked at just hospitalization and mortality and control for kind of a long list of covariates, which we can go into detail of slightly later. So this is just a quick overview of kind of the cohort that we ended up from applying that. And just to highlight here, so for the first objectives, because of kind of the breadth of this data set, we know we're just under 1 million individuals who had atrial fibrillation and a CHA2DS2-VASc score greater than or equals 2. You can see even for the subgroup of medications, you still get really well-powered cohorts. And then for the COVID-19 event grouping, it's about 8% of that group, so 77,000. So then looking at some of the results now, and so first looking at these estimates of antithrombotic coverage. A quick thing to flag up front, which might be actually interesting for other people doing analysis in the consortium. So you see the total individuals with AF and CHA2DS2-VASc score over 2 did rise by kind of moderately by around %, but actually the background population data, so even just those registered with RET, went up by about 5%. So some artifact here in the data that was kind of still exploring. So we're not inferring too much from this top line figure. However, when we look at the subgroups of different antithrombotic classes, we see the kind of those middle 2 blocks. That's what will be described as not optimal according to broadly international guidance. So antiplatelets only, slightly lighter blue, and then no antithrombotics at all, slightly dark. And you can see that the number of individuals on no antithrombotics is still around 12%. So compared to one of the most recent evaluations in the UK, that's kind of marginally improved, but it seems to be a kind kind of a solid base there that's harder to penetrate. Then on the antiplatelets only grouping, you can see that actually that's improved quite a bit since the last evaluation. So that is positive. We then looked at actually individual drug classes. So with the previous slide, they were mutually exclusive groups. So you had to be in one, whereas this could capture, individual could be on, say, warfarin and aspirin. But it's still interesting to see kind of a clear trend from warfarin prescriptions falling across a period, whereas DOACs rose. And this is kind of a direct result of guidance that was given at the start of the pandemic, because warfarin requires in-person monitoring, and so for obvious reasons there was a shift to try and move away that. And it kind of shows how you can track and then feed the data back into helping making these kind of rapid nationwide medication policy decisions. And then now looking at some of the factors associated with a lack of antithrombotic use. So on the left-hand side, you can see kind of the pre-selected factors that we tested, and these came from previous evaluations. The subgroups, there's a Shiny app where you can see a lot more detail of the different stratifications, but here we're just looking at any antithrombotic versus no antithrombotic. And kind of as you'd expect on the first block of comorbidities, the comorbidities that make up the Chances score, they do increase the odds of being on antithrombotics, which is what you'd expect, and particularly with vascular disease and stroke. And then conversely, comorbidities that are signaling future bleeding risk, so that particularly make up has bled score, like liver disease, they lower the risk, and that does broadly follow clinical guidance. Perhaps a more interesting finding here is around history of fall. So there is a fair amount of literature on this showing that historically history of fall has been used as a signal for assessing bleeding risk. But actually perhaps the risk of stroke in this group is higher than that of bleeding risk, and perhaps there is a subgroup here that would benefit from being antithrombotics that aren't. Looking then at demographics, because the second block down, so the results observed here that women have lower odds of antithrombotic use. Actually, this is likely a result of the CHA2DS2-VASc scoring mechanism, where women get a point and men get 0. So typically there'll be a healthier group and less likely to be on antithrombotics. We do, however, then see differences across ethnicity, socioeconomic status, and geographic location, where broadly, individuals who are not of white ethnicity and have lower socioeconomic position have lower odds of antithrombotic use, and that ties into broader systematic health inequalities that we see elsewhere. So now lastly, looking at then some of the COVID-19 outcome results, so the third objective. Worth staying here, so we used multivariable logistic regression, but also Cox regression, and I'll show the sensitivity results for that next. And in the multivariable regression, so this is kind of a binary event outcome, we did adjust for a propensity score for taking antithrombotics, and we also tried to control for the listed covariates at the bottom of this slide, but accepting that there are inevitably residual confounding that's very hard to control for here. Give a sense of the numbers. So again, we picked up before, there's around 77,000 people in this cohort, about half of whom were hospitalized and about a quarter who sadly died. And what we see from looking at this is there does seem to be some modest protection for those who are on antithrombotics from death, but not of hospitalization. Which is perhaps slightly counterintuitive, but there are possibly a couple of explanations for this. So one could be that if you're on an antithrombotic, you actually already have higher health-seeking behaviour, or you're more likely to be interacting with the health service anyway. So that could be a behaviour-driven one. And an alternative explanation would be actually the protective effect of antithrombotics might only kick in at the most severe end, so you'll still get ill enough to go to hospital, but it might protect you from death. And we saw the same pattern in anticoagulants versus antiplatelets, but not in DOACs versus warfarin, where there was no difference in mortality, but there were some reduced odds of hospitalization, which is positive given that shift we saw earlier from warfarin to DOACs. So as I mentioned, we ran multiple regression analyses and time periods to check for concordance. So this is now showing hazard ratios from time to event and Cox regression. Again, you see the patterns are very similar. We also looked at just an earlier time period We did have vaccine status control for in these analysis, but we want to look at kind of an earlier sub-segment of the wave anyway. And as you can see, both the pattern and the effect sizes are broadly similar, which suggests concordance. So in terms of kind of what next, so as I mentioned, these are interim results. We're still drafting the manuscript now, and we kind of welcome input from the consortium, which we've already had lots of, which is great. And hopefully, if I have an efficient week, I'll get that around to the consortium this week for some wider input. We do want to try and replicate this in Wales and Scotland. We had some initial conversations, and there are a couple of challenges here. We want to try and work through, but it'd be great to be able to do that. And then, yeah, this is kind of very much a first step to getting to some more personalized risk predictions for how you could inform medicating decisions in these individuals. So particularly how you can then build more personalized stroke and bleeding risk predictions, so we can kind of capture that coverage a bit better. So anyway, I'll pause there, and yeah,